Hello and welcome. This is a clinical review from Dr. Emik Anesthesiology. Today we're going to take a close look at the reversal of neuromuscular blockade with a specific focus on the clinical use of neostigmine.
Now, before we proceed, please keep in mind that this presentation is for educational purposes only. It's based on the excellent article from Open Anesthesia, Reversal of Neuromuscular Blockade, Neostigmine, which was updated on April 6, 2023. This is not, of course, a substitute for your own professional clinical judgment.
So here's our roadmap. We'll start with the risk of residual blockade, which is really the why behind all of this. Then we'll cover neostigmine's mechanism, get into the specifics of monitoring, dosing, and timing, and then discuss its critical limitations. After that, we'll talk about mitigating side effects and wrap it all up with the key clinical takeaways.
Okay, Section 1, the risk of residual blockade. This is the fundamental patient safety issue that makes understanding reversal agents so absolutely critical in our field. So what are we talking about here? Residual neuromuscular blockage, or RNMB, is exactly what it sounds like. It's the leftover paralysis from neuromuscular blockers after surgery. And this isn't a minor issue. It poses a very significant risk of serious problems, especially respiratory compromise.
This number right here, this is our target. A train of 4 ratio of 0.9 or greater. This is the objective, quantitative proof we need to confirm that the patient has adequate strength back for a safe tracheal extubation. Anything less is unacceptable.
All right, let's move on to Section 2. How does neostigmine actually work? Well, it all comes down to its role as an acetylcholinesterase inhibitor.
The mechanism is pretty elegant, really. First, neostigmine blocks the acetylcholinesterase enzyme. That enzyme is what normally breaks down acetylcholine, so by blocking it, the concentration of acetylcholine at the neuromuscular junction goes way up. With so much more acetylcholine floating around, it can outcompete and push the neuromuscular blocking agent off the nicotinic receptors, and just like that, neuromuscular transmission is restored.
Now for Section 3, monitoring, dosing, and timing. I want to be really clear here. This has to be a data-driven approach. Reversal isn't just something we do routinely, it's a precise intervention.
And that brings us to this point, which I can't stress enough. Neuromuscular monitoring isn't optional, it's essential. Using a peripheral nerve stimulator, and ideally quantitative monitoring, is the only way to accurately determine the right dose and the right time to give neostigmine. It's fundamental to patient safety.
This table really lays out the dosing strategy for us, and it's all based on the train of 4 count, how many twitches you actually see. Look at that top line. For a deep block, a TOFC of 0 or 1, reversal with neostigmine is just not recommended. It won't work. For a moderate block, with 2 or 3 twitches, we're looking at 0.04 to 0.07 milligram per kg. And for a minimal block, where we already have 4 twitches, we can use a much smaller dose.
So you've given the dose. You need to know that the peak effect is going to hit at about the 10-minute mark. If at 10 minutes your train of 4 ratio is still below 0.9, that's a red flag. It tells you there's a problem. Either the dose wasn't enough, or, more likely, the block was just too deep for neostigmine to overcome in the first place. Okay, let's talk about the tough stuff. Section 4 covers the critical limitations of neostigmine. Understanding the ceiling effect and the danger of paradoxical paralysis is absolutely imperative for any practitioner. It's really important to distinguish between these two phenomena. On one side, you have the ceiling effect. This is when you've already inhibited all the acetylcholinesterase you possibly can. Giving more neostigmine does nothing. It's why you can't reverse a deep block. On the other side, you have paradoxical paralysis. This is actually caused by an overdose of neostigmine. You get so much excess acetylcholine that it causes a sustained depolarization at the motor end plate, and the result, counterintuitively, is more weakness.
And this quote from the source material really drives the point home. If you hit that ceiling effect while trying to reverse a deep block, you're done. Your only option for recovery is to wait for the patient's body to metabolize and eliminate the blocking agent on its own. You're now relying entirely on spontaneous recovery.
So on top of its limitations, we also have to actively manage its side effects, which are inevitable. That brings us to Section 5, mitigating the muscarinic effects.
Because we're flooding the whole system with acetylcholine, not just the neuromuscular junction, we get these widespread muscarinic effects. Cardiovascularly, that means bradycardia. In the respiratory system, you can see bronchospasm and increased secretions. And of course, there are the GI effects like increased salivation and motility.
So how do we handle this?
Well, the standard of care is to give an anticholinergic agent at the same time.
Glycopyrrolate is a common choice because its onset time matches neostigmines pretty well, allowing it to effectively block those unwanted muscarinic effects. You are listening to the Dr. Melanelic series.
All right, let's bring this all together in our final section, synthesizing the absolute best practices for using neostigmines safely and effectively.
If you take away nothing else, let it be these 4 points. 1. Always monitor and use quantitative monitoring if you have it. 2. Be patient. Wait for some sign of spontaneous recovery, ideally a TOFC of 4, before you even think about giving neostigmine. 3. Dose appropriately. Titrate based on the data from your monitor. Don't just give the maximum dose every time. And 4. Confirm your reversal. Make sure you've achieved a sustained 3-to-4 ratio of 0.9 or greater before you extubate.
You are listening to the Dr. Mech series. Please subscribe and hit the bell for updates on future clinical explainers.
So, I'll leave you with this final thought. We now have newer reversal agents available. So what is the enduring clinical role of a workhorse drug like neostigmine today? It's a critical question that helps us place this foundational knowledge into the context of our evolving modern practice.